And if you believe with me, rise on your feet and let's sing together. Yo, 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 yo. Well. Good morning, everyone, and welcome to this year's PATA Summit, the face of care. Health providers and communities at the front line of pediatric and adolescent HIV service delivery in Africa. Karibuni sana, that's what I say in Swahili from Kenya. Before I introduce the speakers for the opening session, we are going to try to go live to a few of our 22 satellites, where nearly 800 frontline providers are attending in person, with more also attending virtually. My name is Patrick Oyaro, and I'm your chair this morning, and I invite Luane to help me introduce the satellite sites. Welcome, Luane.
Thanks, Patrick. Thank you. We're going to try with Kenya first, and I am going to ask AREP if they could give us a good Mexican wave and say hello to everybody. So AREP, I hope you're there. I can see you. You need to put your mute off so we can hear you. Okay, can we hear you and see you? Can you shout?
We are. So this is team satellite from Kenya, Homa Bay. How are you?
Karibu, AREP, Homa Bay, Kenya. Okay, welcome.
Wonderful, thank you. We're going to now go down a little south and going to Blantyre in Malawi. Blantyre, if you can unmute. On. Okay, Blantyre, you're taking a little too long. We're going to maybe try go to Eswatini and see if they faster to hit the unmute and camera button. Eswatini. Ah, can we hear you? We can't hear you. Great. I'm not sure. There's no sound. I'm not sure why we can't hear Eswatini. Wonderful. Great. Thanks, Eswatini. Thank you. We couldn't hear you, but we could feel all the exuberance. We're going to try go to Cameroon, to Jude. I'm hoping, there we go. Cameroon.
Yes. Welcome.
Wonderful. We've got a side view. Gosh. Ah, wonderful. There we go. We can't hear you. Great. Great. Wonderful. Thank you. And I see Blantyre is with us now. So thanks, Cameroon. We're going to end with Blantyre, and then I'm going to hand over to Dr. Patrick, and then we'll visit a few more satellites. So Blantyre, over to you. I don't know why we can't hear everyone, but...
Oh, wow. All right. Great. Thank you for the 4 teams that have shown us where they are, and we can feel the energy. We will be trying to visit satellites through the 3 days. So let's keep up the spirit. Just get ready. Please use the Q&A or the chat function to post any questions to the presenters through the session. And let's use the translation icon for French, Portuguese, and Kiswahili translation. This morning, we have a few presenters in the session who I will introduce. I will not provide their full bios, as these are all on the Linking and Learning Hub. Please read them there under Summit contributors. So first off, we have Luann Hatan, who is the Executive Director of PATA, who will provide an overview and explain a little more on the face of care and the importance of this year's Summit title. After that, we will go straight into the next presentation from Dr. Shafiq Esaji, who is the Deputy Chief of UNICEF's HIV program and also serves on the PATA board, to provide an overview, update, and progress made over the last year in the new Global Alliance to End AIDS in Children. We need to end AIDS in children. So Shafiq is not here with us this morning, given the time difference, but we are grateful to have Tim Msinguzi from UNAIDS and Wole Ameyan from WHO, who are available to answer all our questions. I will invite the team to take us to the next level. Over, back to you.
Greetings to everyone. Good morning, good afternoon. Following on from the chair, a huge and warm welcome to the PATA 2023 Summit, titled Face of Care, Health Providers and Communities at the Frontline of Pediatric Adolescent HIV Service Delivery in Africa. Why is this year's summit titled Face of Care? Well, it really builds on the workshop that many of you were part of last year, which was actually called Face of Care. And whilst many of the presenters during the summit this year will prioritize and speak to the importance of children, adolescents, and young people, ongoing HIV incidents, and persistent treatment gaps, across the HIV response, we've seen a real focus on service delivery improvements, new programming, and community engagement. Yet often we don't see sufficient attention being placed on those on the front line. Those who deliver services have to implement the programs and who are critical and central to delivering friendly, stigma-free services. This summit very deliberately, therefore, focuses on you, all of you, delivering services on the ground. This year's summit is therefore about positioning health providers as key partners and champions in ending AIDS for children and adolescents by 2030. It highlights your priorities, your experiences, sharing lessons across clinic staff and community partners, providing a space to share your challenges, your lessons and experiences with a real reality check between global, regional and country commitments to the everyday local realities faced in delivering services. When we look at the actual numbers, this year's summit had 1,775 registered participants last week. Hopefully this number has already grown. We have 765 attending in person through 22 satellite hubs stationed across 13 countries, with many others also attending online. The 5,000 registered members on the Pata Linking and Learning Hub also have full access to the Summit online program. And across all those registered participants, we see a great mix of both health provider roles and community partners. The program, which you have all seen, if you just focus on the orange section, you will see that each day starts with the in-country orientated program. This is organized by the satellite hosts and managed and run in country. The virtual program starts after that, and that's where we all connect across countries. And this includes both a prime session and 2 Africa Cafe sessions, with the afternoons on day 1 and day 2 dedicated to in-person workshops at all sites. Day 3's afternoon looks a little bit different and will also be virtual, including both a Pata Reel and a closing Lekgotla session. The summit is across 3 days. Each day holds a particular theme. Day 1 builds on the actual summit theme of Face of Care, what it takes to create an enabling and supportive environment. Day 2 focuses on service integration, transformative approaches, and focuses primarily on disclosure, which emerged as a strong area from last year's summit that health providers said they felt they needed more support on. Day 3 focuses on advanced HIV disease in children and will also feature updates on optimized treatment. Last year, many of you participated in the Face of Care workshop, hence the summit this year is themed all around that. And this forms part of a broader and ongoing piece of work that Pata is undertaking and a study to really better understand the contextual realities of frontline health providers in the pediatric adolescent response. It's aimed to explore, document different experiences, challenges, and really wanting to understand what are resilience promoting factors and what constitutes an enabling environment for frontline providers. 801 participants attended across sites and participated in this workshop and study last year. Nurses, peer supporters, and NGO staff were the most common occupational category, followed by psychosocial support staff, counselors, and social workers. You will recall from last year's workshop, we had several activities which included mapping, sticky notes, and word association. And all of these were then ranked into different priorities, and focus group discussions were also held. Within the mapping and prioritization, when asked what would make me feel empowered and supported in providing pediatric adolescent HIV or sexual reproductive health services, you can see some of the ranking from highest to lowest, included areas like training, capacity building, peer support, supervision, mentorship, financial resources, physical infrastructure, adequate resources to complete work, meaningful engagement and communication with young people, stakeholder and community relationships, and having supportive policies. Findings from the focus groups were strongly aligned, with also areas like self-care and mental health coming up strongly as areas of concern. I'm going to talk through some of the main findings from all of the work that you all participated in last year. And we're going to try and do it a little bit creatively using some pictures that were developed by Pata, the researchers at Western University, with the support of a local artist. At an individual level, we can see that mental health and well-being emerged as key areas, especially when having to listen to difficult stories being told by children or their caregivers, as well as having to deal with job-related stress and heavy workloads. At the interpersonal level, there were three main themes. This included acknowledgement and appreciation from colleagues and clients, supportive supervision and mentorship, as well as teamwork. Being acknowledged and appreciated for work was described as morale boosting and motivating. Unfortunately, many of the discussions reflected that many health providers sadly don't feel appreciated or acknowledged in their work. The need for supervision and mentorship that's empowering and supportive versus punitive was also highlighted. Many of you also said it's important to have a safe space to ask questions or troubleshoot, as well as being able to debrief and discuss emotional impacts of work-related challenges. Participants also described the need for greater teamwork in their facilities, for knowledge sharing, capacity building, just sharing one's workload, and being able to come together around a joint shared purpose. Teamwork was definitely understood to strengthen clinical services, contract tracing, to creating a positive work environment. But again, unfortunately, many participants describe less than ideal realities in practice, feeling unsupported with splintered work environments, and with most teams described as being under severe strain. At an organizational level, resources were discussed actually across all the sites, across all the occupational groups. And this was across financial resources, supplies, issues around stockouts, as well as human resources. Physical infrastructure was also raised as an area of concern in terms of having limited space that inhibited privacy and didn't allow for confidentiality. While many had described that, you had access to youth-friendly corners, often these were repurposed and also often shared with others. Many health providers felt, this created stress and definitely was a deterrent as young people didn't want to attend the clinic, especially when they felt their confidentiality may be compromised. When it comes to financial resources, this was discussed in light of remuneration, issues around transport, visiting clients, as well as concern in terms of funding to be sustainable for programs to continue. But remuneration definitely came out as one of the biggest priorities across the board. And remuneration was definitely linked to being motivating, empowering, building trust, and was a real incentive in terms of performance. And whilst this was raised across all different occupational groups, it was felt in slightly different ways by different groups. Community-based peer supporters, counselors, and community health workers, for example, really described, feeling that they often had to work for free, their stipends were inadequate to support their basic needs, and they didn't feel sufficiently recognized or incentivized. For many other health care providers, they raised issues of staffing, human resources being under strain, not sufficient staff or trained staff to manage the kinds of caseloads and demands. with many sharing that they were stressed and overstretched. And in the face of that, also having to deal with their own financial challenges often, with many reported, not being remunerated fairly, and often also not being paid regularly or on time. Many participants also described, inadequate training, feeling like they didn't have sufficient tools, guidelines, job aids to effectively provide up-to-date support and services. Also, raising concerns that often the guidelines, the technology, biomedical technologies are changing quite often. The landscape is shifting quickly, but updates and training come late, if at all, with particular gaps and concerns around not feeling sufficiently equipped to manage mental health issues, as well as working with young key populations. At a structural level, in many countries, it was seen that there was restrictive sexual reproductive health and rights policy frameworks, and this was felt to create lots of barriers in terms of service or ability to deliver services. And this was described in relation to high age of consent, limitations to termination of pregnancy, homophobic legislation, and criminalization of key populations, making it difficult and really creating dilemmas for frontline providers in being able to deliver the services that are needed. And in particular, also having huge impact in breaking down trust and a lack of confidence with their clients. At a community level, positive stakeholder relationships between clinics and CBOs, community-based organizations, was seen as hugely important, helpful in providing holistic support, reducing clinic loads, and meeting some of those broader psychosocial aspects that often weren't accommodated in terms of services in the clinic. And throughout the program and throughout the next day, you are going to explore different areas around the Face of Care workshop in a little bit more detail. And I think many of the areas, the recommendations and the areas of concern that many of you raised last year, you will see all of those highlighted throughout this year's summit program. And that is in a direct response to addressing the recommendations and the concerns that were raised by yourselves. So I think just in closing, just wanting to thank everyone who did participate last year and gave such wonderful input into the study, and continue to work with PATA in being able to really be and share the voice of those providers on the front line. And just wishing you all a wonderful 3 days, a wonderful summit. I look forward to seeing and meeting you all online over the next couple of days. Please have lots of fun. I'm hoping you're all going to do your dance challenges, share lots of social media, and really make the best of the 3 days, especially for all of those sitting at a satellite site and being able to be in person. Thank you so much.
My mother is a photographer. She took these. She loves taking photos and loves telling stories. They are about HIV.
There have been so many sad stories. Even though I know they are real, I sometimes find it hard to believe.
For 40 years, there have been so many stories of loss and despair. of fear and stigma of discrimination.
Some of these people look so sad.
But there was also hope.
Wow.
People changed laws through activism and political struggles, and there are so many scientific breakthroughs.
Do you believe we can end AIDS for children?
Today, AIDS care is not as costly or complex, but still challenging. Even with all the achievements, sometimes I look at the photo and think the world has forgotten that HIV pandemic continues.
There's still so much to do.
These photos tell stories of many people who no longer face death from AIDS. My mother's photos tell the stories of people who need a blueprint for change.
We need to remind the world of their promises and commitments.
And so many people have joined this fight against HIV and AIDS, because the world's largest challenges need the world's largest team.
I like these photos. Wow.
We do not get to choose what we face in our lifetime, but we just get to choose how we respond. It's time to galvanize action, build on lessons learned, and realign programs to meet the ambitious targets agreed in the declaration. And we must now come together to commit to implement the blueprint of the Global Alliance over the next 9 years.
I believe we can do it. What should be hung here on this wall?
Well, today, at the launch of the Global Alliance, you will all decide together what hangs on the wall.
We need to believe that together we're going to end AIDS in children, once and for all.
Good evening, good afternoon, good morning, friends and colleagues. It's fantastic to join you virtually. I wish I was with you in person, because the energy that we get from each other during the PATA summits is really vital to sustaining us, sustaining our determination to work together. My name is Shafiq Isaji. I'm the Senior Advisor for HIV at UNICEF. And I'm going to speak to you today and offer some global perspectives and priorities on what we need to do to close the gaps for children living with HIV. It seems that everywhere you look today, you see the words equity when it comes to the global AIDS response. In fact, UNAIDS has made equity the central theme of the latest global AIDS strategy. So I thought we could start by talking a little bit about what equity actually means. Equity refers to a sense of fairness and justice, and recognizes that health is a right, and to achieve that right for all, we must overcome the biases that have resulted in some populations being neglected. Now, I think children and adolescents living with HIV are perhaps some of the populations that have experienced the greatest inequity in the AIDS response. And the global numbers show it all. This is the treatment cascade among children and adolescents at the end of 2022. And as you can see, only 57% of children globally were receiving antiretroviral treatment. That's 20 percentage points less than adults. And if you look across the whole continuum from testing to treatment to viral suppression, you see the same inequity persisting, where children are faring much worse than adult populations. In fact, if you were to look at deaths relative to the total population of people living with HIV, children contributes 13% of all deaths due to AIDS, despite representing only 4% of all people living with HIV. And when you look within the Africa continent, the inequity is perhaps even more marked. Now, I don't want to dwell on these images for too long, because I know they'll be hard for you to read them. You will have the slides and can review these data later. But in each of these figures, we've got a comparison of Western Central Africa and Eastern and Southern Africa. So on the left, we're looking at HIV programs, and we're comparing the percentage of numbers of children living with HIV. We are looking at the percentage of infants who were born to pregnant women who received testing within 2 months of life. And we're looking at the percentage of pregnant women who were accessing treatment during pregnancy and breastfeeding. The little red box represents Eastern and Southern Africa, and the green box represents the data from Western Central Africa. So you can see that coverage of ART is much lower in both women and children in Western Central Africa. And when you look at testing, only 1 in 5 exposed infants get a test for HIV in Western Central, compared with 4 out of 5 kids in Eastern and Southern Africa. On the right-hand side, we're comparing the epidemics at the end of 2022. And what's interesting is that in Western Central Africa, even though the incidence is much lower, when you look at deaths, especially in the 0 to 14 age group, they're about the same. The total AIDS deaths in children 0 to 14 in Eastern and Southern Africa was 35,000. And in the same year, it was 34,000 in Western Central Africa. So this inequity is resulting in a shift in the epidemic with a greater importance from the countries of Western Central Africa compared to the countries of Eastern and Southern Africa. The new Global Alliance to End AIDS in Children brings us some hope to try to address this inequity. We've spoken about this in PATA before, and as you know, it's a global initiative that follows on from the global plan and the 3 frees that you knew about. It's a little bit different, though, to those other initiatives. And the reason why it's different is because this is a country-led, not a top-down initiative. So we're actually asking the countries to drive the work of the Alliance in country. And that is given prominence in the structures and in the systems that the Alliance is putting into place. The other thing that's important is that the Alliance focuses on 4 pillars that include pediatric testing and treatment. It includes PMTCT and prevention of HIV among pregnant and breastfeeding women. But it also includes addressing the structural barriers, gender equity, social and structural barriers that are hindering access. And finally, it's not focused on different populations. The idea is to have one objective, which is to end AIDS in children. So even though there are these different pillars, the way it's put together is to ensure that things are working in concert and that we have one focus to try to achieve an end to AIDS in children. This is what the structure of the Alliance looks like. And the thing that's important on this slide is that PATA is actually within each of these structures. PATA is a key member of the steering committee that provides worldwide leadership. PATA is represented in the global working groups that are thinking about some of the technical needs for countries. PATA is in the regional hubs, supporting WHO, UNAIDS, and UNICEF to provide technical assistance to countries and support countries in reporting. And PATA members are part of the teams in country that have been convened to lead and direct the response. So the Alliance is critical to our work within PATA. What progress have we seen? Detailed country action plans have been developed, and many of you have been involved with the development of these plans in your countries. We've also formed a number of the technical and regional groups that are necessary to support the work. And data snapshots have been updated for each of the countries so that you can see at a glance where countries are in their response. We've worked hard to ensure that the Global Fund and PEPFAR are including these action plans and the priorities of countries within their national plans. And we've worked to raise funds to identify advocacy champions, both within PATA and with other networks of frontline health workers and communities of people living with HIV, to advocate for and support the response in country. We've developed new guidance. There is emerging guidance on PrEP in pregnancy, a triple EMTCT guidance note, and a pediatric case finding guidance note, which will be coming out later this year. And most important of all, countries met in Tanzania in February of this year to sign the Dar es Salaam Declaration. Now, I don't want to dwell on this declaration for too long, but it's worth noting that these are the things that our governments have agreed to. There are 10 points. There's a link in this slide below that you can click on to see the full text of the declaration. But I want to emphasize that PATA was one of the signatories to this declaration, so we are front and center as part of the response. What does this actually mean for our work? Now, if you look at what the Global Alliance has defined, there are a number of different strategic priorities that are listed within the Global Alliance documents as things that are important for programs to focus on. And as I look at that list today, I think there are 3 critical priorities from among that list that are really important interventions for the PATA family to take on board. They address each of the 3 95s, and in sequence, they are finding children through case finding and especially family index testing, linking children with HIV to care and treatment, and scaling up the use of dolutegravir in order to improve viral suppression rates. As I noted at the beginning, there are something like 700,000 unidentified kids, and we're not going to find those kids through early infant diagnosis. These are children that have missed EID. They're already much older, living with HIV. The first of these is finding children through case finding, especially family index testing. When I started off this presentation, I reminded you that there are 700,000 undiagnosed, unidentified children living with HIV. And really, we're not going to find those kids using infant diagnosis. They've already missed out on the opportunities for EID. So we have to get innovative and use other strategies to find these kids. And family-based index testing is a very promising strategy where we follow up the children of adults who are living with HIV and on treatment. Using these approaches, UNICEF and other partners have found a very high yield, something like 13 to 14% of children that get tested using the family index approach are actually found to be living with HIV. So I think this is a really important strategy and really a priority for us all to be focusing on. The second priority is related to the second 95, and this is linking children that we identify to care and treatment. This is, of course, essential to make sure that positive kids are getting the services that they need. And in many countries, there remains a gap between children that are identified as living with HIV and children who manage to get access to the treatment that they need. And finally, the third priority, I think, is to scale up dolutegravir among children to improve viral suppression rates. We've been doing a great job with dolutegravir rollout. As of 2023, CHAI reports that something like 60% of all children living with HIV globally are receiving dolutegravir-based therapy. That's fantastic progress. But again, when you compare it to adults, the number in adults is closer to 90%. So there's a large difference between dolutegravir access in adults versus dolutegravir access in children. And I think this really is a priority area for us. If we could improve the quality of treatment that kids are receiving, we would improve their lives, their health, and their virologic suppression rates. So if those are our priorities, what are the approaches that we as a PATA family can take to really implement these priorities? I think the first idea that I want to put to you is the PATA ripple effect. This idea that you have the skills and knowledge and you can become the hub within your local community of providers to really take that knowledge, take those skills and ripple them out to other sites around you. So use those skills and your knowledge to train and mentor other clinics and other clinicians so that they understand these priorities and can implement them in their programs. I think the second thing is to expand on the work that we're already doing around clinic community collaboration and just recognize that that's an incredibly powerful collaboration that supports us in our work. In many settings, without communities being engaged, children will not access testing and will not access treatment. So reaching out to communities and maintaining that collaboration with communities is really essential. And I think the last piece is to activate the scaling up of dolutegravir by using your local data to advocate for resources for children. You know how many kids are accessing dolutegravir in your clinics and in the clinics that you're mentoring and supporting. Use that information to go back to our partners in ministry and say, there's a problem here. Children are not accessing the best quality services that they could be. So I want to close by just taking a little quote from the Dar es Salaam Declaration that I think is important for us to bear in mind. What our ministers said when they got together in Tanzania earlier this year was that we request all stakeholders, including civil society, faith-based organizations, religious and community leaders, local implementers and partners to work with us and embrace this opportunity to save and change lives. Together, we can build a legacy that allows children living with HIV to reach their full potential. So I want to close with those notes and thank you very much for your attention. I know that you'll be working hard thinking about some of these approaches and strategies and how you can scale them up. And I think we have a critical opportunity ahead of us. The Alliance has really built a lot of momentum in the global community and gives us finally a voice at the global level to talk about children, to talk about the inequities that they face, and to show people that we know exactly what needs to be done as long as we're given the priorities and the political momentum to be able to see the job through. Thank you very much for your attention.
Wow, thank you. Let's appreciate the presenters. Thank you, Luane, for that. The UNICEF video was really challenging. We've been told to galvanize the action. And I'm waiting to see what will hang on your wall, just as that little child asked. I believe that we can do it. Without much ado, I would like to introduce and welcome Dr. Nelly Phatho Dindi. Dr. Dindi is a Senior Assistant Director of Medical Services at NASCOP in the Ministry of Health in Kenya. Dr. Dindi will provide updates on Kenya's plan to end pediatric AIDS and progress that Kenya has made since the adoption of the Dar es Salaam Declaration. And this was part of the Global Alliance to End AIDS. Over to you, Dr. Dindi.
Thank you very much, Patrick Oyaro, for that introduction. My name is Dr. Nelly Phatho Dindi, as I've been introduced, and the PMTT Program Manager in NASCOP, and I'm actually representing our Head of Division, NASCOP, Dr. Rose Wafula, in this PATA Summit, and for this presentation. And I'll straight away go and ahead and make the presentation, if you will allow me. Thank you. Yes, so I'm going to briefly just give a report or maybe a progress report of how we are doing as Kenya after the Dar es Salaam Declaration on the 1st of February of this year. Next slide, please. Yes, so this is where we are at as a country in terms of the progress of ending AIDS among children in Kenya. We have approximately 68,000 children living with HIV AIDS currently. And out of this, 6 children die daily due to HIV/AIDS and its complications. And we also have 12 children being newly infected with HIV every single day. And majority of this, giving a percentage of 67% of the new infection of these children aged 0 to 14 years is being attributed to either pregnant and breastfeeding women not having their ARTs or having their treatment interrupted. Currently, the optimum regimen for children is DTG, and the middle diagram, which is represents the map of Kenya, gives a representation on how we are doing in terms of the DTG coverage. So we can see that most counties are in the darker areas, meaning that our coverage is less than 20% for DTG, and the lighter colored counties are those that are having a coverage of between 80 to above 90%. The third diagram on your right, the right of the screen, is our mother-to-child transmission rate. Currently, the national rate stands at 8.6%, with differences or discrepancies in, different representation of the counties, where we are also having from the map, the dark areas also having a higher mother-to-child transmission compared to the counties that are represented by the lighter colors. Okay, so I was talking about the mother-to-child transmission rates. Nationally, we are at 8.6, and it's different in different counties as represented in the map, where the dark colored counties are those that have got a higher mother-to-child transmission rate as compared to the counties with the lighter colors across the nation. Next slide, please. Yes, so this is our performance as of now across the different indicators. So we have where we are currently at vis-a-vis where we want to go, or our targets. So for our maternal ART performance, currently we're at 90%, and we want to have all mothers that are HIV positive being on ART. For infant prophylaxis, currently we're at 75%, and our target is to have all children that are exposed to HIV being on infant prophylaxis. Our MTCT rate, as I've already mentioned, we're at 8.6. Our target is to get to the less than 5% for us to be able to achieve elimination of mother-to-child transmission of HIV. And for our children living with HIV on ART coverage, we are currently at 85%. Our target is to get to more than 95%. For the CAL HIV viral load suppression, we are currently at 75%, and we want to get to 100%. And for the CAL HIV ART optimization on DTG first line, we are currently at 92%, and the target is to have every child being optimized and being on DTG regimen. Next slide, please. Next slide, please. Yes, so Kenya is among the 12 inaugural countries to shape the Global Alliance agenda. And as members of the Global Alliance, we were part of the declaration that was made in Dar es Salaam, as I've already mentioned. And in that commitment, there was a development of a 4-point action to bridge the gaps to fast track the progress of ending AIDS in children. And these action points, the first one is to address vulnerabilities and inequalities that sustain the new infections and impede progress by subpopulations and geographies. The second point is that we want to close all the bottlenecks in the diagnostic systems, commodity security, and health workforce that have really been a challenge. Then point number 3 is to renew partnerships and align resources with country priorities and costed work plans. And then the last but not least is to prioritize data and information system to have an informed science-led response at all levels. Next slide, please. Okay, so we are working with the two main objectives of ending AIDS in children by 2030. The first one is to close the tap in elimination of mother-to-child, where we have eliminating of all missed opportunities in mother-to-child transmission, cascade of care, and then longitudinally following up the mother and the infants so that we ensure that there are no missed opportunities occurring thereafter. And the second objective is to end pediatric AIDS where there is aggressive case finding. And after we have identified the children, and then we are able to optimize them on care so that we achieve viral suppression. Next slide, please. Yes, so this is the call of action that we are working with as a nation. We know that once a child has acquired HIV, without the appropriate care and treatment, about a third of them die by their first birthday. 50%, that half of them get to the age of 2, and 80% get to the age of 5. And so it is very important for us to have timely initiation and support for HIV treatment to pregnant and breastfeeding women, who so that we are able to reduce the mother-to-child transmission, which is really the cornerstone of giving every child a free start. But additionally, going ahead to have timely testing and treatment of children who are HIV infected, which is critical to prevent them from deteriorating to AIDS and dying. And really, this is the theme that we are running with after the declaration and the commitment was made on behalf of the nation by our CS Health. And right now we are running with the theme of Wakati ni sasa, meaning the time is now. Let's end AIDS in children. Next slide, please. So these are the steps that we have taken as a nation to fast track the commitment that was made. The first one is swift translation of scientific evidence into policy. Number 2, implementation of robust policy and strategic frameworks. Number 3 is having an approach that engages all levels of governance, different sectors of the economy, various stakeholders, partners, including the private sector, faith and religious communities and traditional community value gatekeepers, but also deliberately focusing on those that have been left behind. And this includes the adolescent and the young people, populations that are living in rural or informal settlements, arid and semi-arid, that as we commonly call them, ASAL counties or ASAL areas, the men, the private sector, and also the religious community. Next slide, please. So overall, this is our progress. As of now, we had an oversight and technical committee being appointed by our Director General at the Ministry of Health, and also having these teams have been activated, and they have got representation from the Ministry of Health, that is the government, both at national and county level, the communities, the partners, including UNAIDS, UNICEF, WHO, Global Fund, and PEPFAR. We also have representatives from the communities and main key stakeholders as being part of these committees that are really pushing the agenda forward and working together. We've had the finalization and the launch of the Kenyan Plan to End AIDS in Children, which is a document that was collaboratively developed by the Ministry of Health through NASCOP, which is the National AIDS and STI Control Program, through extensive multi-agency consultations for a transformative journey that aligns ending AIDS in children. And this plan is in line with several other agenda and documents in the nation, including the Kenya Kwanza Government Agenda, the Kenya Health Sector Strategic Plan, Universal Health Coverage Plan, the Vision 2030 for Kenya, the Kenya AIDS Strategic Framework, and the Global HIV, AIDS and Health Commitment. We've also had an increased momentum through a rapid results initiative that was flagged off on the 8th of September, at the same time when the Kenyan Plan to End AIDS in Children was being launched. And this rapid results initiative started in the month of September and is to end on the 31st of December. We've had resource mobilization through reprogramming and inclusion of interventions under the Kenyan Plan to End AIDS by 2027 in proposals such as the GC7 application and the COP23 application as well. And we've had several other partners, both health and non-health organizations coming together to just mobilize resources to move the agenda of ending AIDS in children by 2027 together. We've also had multi-sectoral partnerships, collaborations with other sectors such as the Ministry of Education, Child Protection, and we've had multi-divisional involvement even in the Ministry of Health, like the Division of Mental Health, Division of Gender-Based Violence, Reproductive Health, and Neonatal Child Health. Next slide, please. So these are photos from the launch that I have just mentioned, where we were launching the Kenyan Plan to End AIDS in Children, but also to flag off the Rapid Results Initiative for prevention of mother-to-child transmission, and also the CAL HIV care and treatment. And we can see our CS Health together with other dignitaries being part of the launch that happened on the 8th of September. Next slide, please. So as I've mentioned, we are working with the Kenyan Plan to End AIDS in Children by 2023. And on the left of the screen is the cover page of the plan itself. And the plan really has got, our vision is to have a world that is free of HIV. And also for us to achieve this, we are mobilizing leadership, partnerships, funding and action to end AIDS in children, with the goal of ending AIDS in children in Kenya by 2027, but also working with the triple elimination agenda. And so we also want to eliminate congenital syphilis and hepatitis at the same time. Next slide, please. So the plan is anchored on 6 strategic interventions. The first one is to address vulnerabilities and inequalities that sustain the new infections and impede progress. And as I've already mentioned, we are targeting the adolescent and the young people. We are targeting the people that are living in the rural areas and the informal settlements and the ASAL areas as well, so that we move together as a nation, and bearing in mind that we do not want to leave anyone behind. But also the other strategic intervention in the plan is to address health system barriers to quality of health services. And also we are looking at supply chain stability and sustainability, because we know that supply chain inconsistencies have been one of the challenges that we have been facing over time. But also the other strategic intervention that we have in the plan is leadership and alignment of resources with country priorities. And that's why we've mentioned that we have got, we've mobilized different sectors and different leadership levels for us to come together, and resources are being aligned towards this agenda. We are also building social capital and community intelligence to end AIDS in children. And so there is involvement of the communities, as I've already mentioned, involvement of key stakeholders, and also what we are calling non-traditional stakeholders that have not been in the elimination of mother-to-child transmission of HIV before, that we are bringing on board in this agenda as we move forward. But also, last but not least, we are prioritizing evidence-driven approaches and information systems. Next slide, please. So part of the plan, or to jumpstart the plan, we, as I've already mentioned, we are now in the period of a rapid results initiative, and this is the approach that we are using for the RRI. The first thing, based on the objectives of ending AIDS in children, is to close the tap in EMTCT. So we're looking at our missed opportunities in the different areas on the indicators and cascade of care. The first one is NC testing and case identification, maternal prophylaxis, infant prophylaxis, hair screening at maternal child health clinics, pregnant and breastfeeding women and the CAL HIV suppression, pediatric optimization, longitudinal tracking of the mother-baby pairs, elicitation and status determination for children of women living with HIV. And the interventions that we are applying are including looking at our records, that's the files, the charts, the EMRs, and the registers, just to identify these missed opportunities, and then also to intensively follow up those cases and manage them appropriately. And we are looking towards having having our missed opportunities that have been identified and traced being documented and reported as true missed opportunities, and then we go ahead and give them the service that they had missed. Next slide, please. And the interventions, we are working with several interventions across several thematic areas. And the first one is to identify missed opportunities across the 47 counties in the country. Then capacity build healthcare workers across all the HIV thematic areas as per the gaps that we have identified. We are also doing supply chain optimization, data reconstruction and management, optimization of viral load and early infant diagnosis, structural interventions for clients, because we have noted that there are clients that will not adhere to treatment or are not being retained into care because of other challenges, for example, lack of food or not having a safe space. So we are looking in this RRI, we are linking these clients to appropriate appropriate structural interventions that are already being carried out by several civil societies and community-based organizations. And then we're having cascaded advocacy, education, and demand creation, and this is at all levels, at national level, at county levels, sub-county, facility level, and community level as well. And then we have communication and documentation of the interventions that we are having in the RRI. Next slide, please. Yes, so I've already said what we have done and where we are at, and we are still really working together as a nation, together with our partners and key stakeholders and technical experts in the different components and areas of prevention of mother-to-child transmission and HIV care and treatment towards the agenda of ending AIDS in children. And these are what is currently ongoing, but also what forms our next steps. We are fast-tracking the nationwide catch-up exercise and implementation of the key priorities outlined in the Kenyan Plan to End AIDS in Children by 2027. There's formation and activation of the EMTCT Validation Committee that is working towards achieving and monitoring the targets in the Triple Elimination Framework, hepatitis guidelines, and the STI guidelines, together with the curriculum. And also we are prioritizing vulnerabilities and inequalities that sustain the new infections and impede progress towards elimination. And I've already mentioned these areas, the ASAL counties, the adolescent and young people, and the urban informal settlements. We're also working, as I've mentioned, with the CSOs to strengthen activism against GBV, teen pregnancy, social and structural barriers of elimination of mother-to-child transmission. But also we have developed and are continuing to develop operational tools to support adaptation and scaling up of new strategies and intervention. For example, the self-testing, the DTG, and other new regimens, including the PLD, fixed dose combination, the point of care EID for children, and new CD4 platforms for advanced health disease. Next slide, please. Thank you very much for listening to me. I hand it over back to Patrick Oyaro. Thank you.
Wow, great. Thank you very much for that, Dr. Dindi. I come from Kenya. I work for LVCT Health, and we care for the children. Thank you for presenting on behalf of Kenya, and I know that there are several other countries who could have given us the story of the progress that has been made so far. We look forward to hearing from them when the opportunity comes. Finally, we have a statement from the First Lady of Namibia. How powerful it is when we get statements from the topmost office. Her Excellency, Madam Monica Gingos. Unfortunately, the First Lady was unable to be here in person, but we are grateful that Dr. Agnes Mahomva, who is a public health advisor to the President and Cabinet of Zimbabwe, will deliver her statement. Both the First Lady of Namibia and Dr. Mahomva serve on the Leadership Council of Africa Reach. Over to you, Dr. Mahomva.
Thank you very much. Hope you can hear me loud and clear.
Yes, you can hear you.
To the chair of the session, Dr. Patrick Oyaro, the organizers of the summit, and honorable delegates, please allow me to say all protocols observed. I am here, as you've just said, to read the opening speech of Her Excellency Mrs. Monica Gingos, the chair of the Africa Reach Leadership Council, and it reads as follows. Ladies and gentlemen, I want to express my deepest gratitude to PATA and all our esteemed partners for granting me this opportunity to speak at your summit, aptly titled The Face of Care, Health Providers and Communities at the Front Line of Pediatric and Adolescent HIV Service Delivery in Africa. It is truly heartening to address the dedicated healthcare providers who work tirelessly to serve children, adolescents, and young people across our continent. Whether you are joining us online or in person at the various satellite hubs that we heard earlier, your efforts are nothing short of commendable. I must extend a special thanks to PATA for creating this invaluable platform which brings together Africa's frontline healthcare workers, giving them the recognition they deserve and a collective voice in the broader HIV response. Far too often, we underestimate the pivotal role healthcare workers play in ensuring vital services reach those who need them most. Our healthcare providers stand as unwavering partners in our shared mission to end AIDS in children. It is heartening to see this year's summit placing a dedicated focus on the collaboration between healthcare workers, communities, adolescents, and young people. Witnessing so many young advocates participating in this summit is truly inspiring. To put an end to AIDS in children, we need to see a surge in political, cultural, and traditional leadership at all levels. In line with the theme of this year's summit, we must witness a heightened commitment across the region. This entails not only prioritizing our children, but also improving the conditions of our healthcare workers. We must ensure that we nurture and retain skills across our continent while simultaneously strengthening our health systems to provide universal healthcare for all. I would like to shine a spotlight on the remarkable initiative of the Africa Reach, a homegrown endeavor dedicated to ending AIDS in children and adolescents on our continent. This initiative embodies the spirit of self-determination, emphasizing local expertise and knowledge to drive sustainable change. Through initiatives like Africa Reach, we not only demonstrate our commitment to this cause, but we also our belief in the power of African-led solutions to revolutionize pediatric and adolescent HIV care across the continent. This summit marks a crucial step in the right direction, and I have every confidence that the discussions and the collaborations that will unfold here will bring us together to our shared goal of an AIDS-free generation. Thank you all, and over to you, Mr. Chair.
Wow. Thank you, Dr. Mahova, for that inspiring address and highlighting the importance of Africa-led solutions. I believe that the team here has taken up that, and we're going to make sure that we implement to the best of our abilities. It's time for questions. Despite the challenges we have had in technology, we have some questions that I would want to invite presenters to quickly respond to them even as we move towards the end of the session. Dr. Shafiq made a presentation, and team will help us respond to the question that was asked. How will the Global Alliance support countries as well as monitor progress? Because I know it's one thing to put a plan, but how will we ensure that we reach the goal, we achieve our objectives? Over to you, team.
Thank you very much, Patrick. It's really a privilege to be in this session and also be part of the opening of this summit, and very inspiring remarks and statements made earlier on. And also for PATA's leadership in this area, we really appreciate and commend the leadership that has been provided. Now, very quickly, with regard to this very important, there are two questions in the chat, and they're actually related with regard to the Global Alliance. Actually, the Global Alliance is already supporting countries in three main areas. The first one, which is very important, given the importance of this subject that Shafiq ably and comprehensively presented is the technical assistance that is provided to the countries, given the fact that the countries really need, the 12 alliance countries that he talked about really need a lot of attention in trying to put together, most important, action plans that can invite the attention of donors. That is one, but also certain technical areas that the countries may not be able to address by themselves, and for that matter, they need support. So that is the most important among other things that the Global Alliance is providing to the 12 alliance countries as we speak. And this is provided at 2 levels. One is through the regional hubs. Shafiq talked about that. We have the regional hubs for Eastern and Southern Africa, as well as for Western and Central Africa. So they are very, very, very important in terms of providing that technical assistance. But also, most importantly, it is also from our technical leads within the UN, notably WHO and UNICEF, for those very technical areas that the countries need support. The second one is that these things cannot just happen without funding. And you know how funding is so critical during this period. Countries may not be able to go to scale with their plans, however beautiful they may be. And what the Global Alliance has done is to put together funding proposals which are presented to donors in order to support the plans at country level. Shafiq talked about the support from Global Fund and PEPFAR, for example, in supporting prioritized action plans from the countries. That is a very important area of support to countries, which we are very proud of as a result of the Global Alliance. The third one, which is also important, is that and this also is related to what Shafiq mentioned, is that this whole Global Alliance is based on the principle of country-owned, country-driven, and not top-down. Now, what has happened is the formation of what we call the country alliance teams, and these are multi-sectoral, whereby the countries should sit down and actually resolve their issues. So this structure is extremely important, and actually in most countries it is chaired by the Ministry of Health, and that is very important for PATA given what you deal with, and also also involves the communities, people living with HIV, and also young people are also part of these country alliance teams. So that is another thing that has come as a result of the Global Alliance. This is a very important structure. Know your problem and resolve it. And then lastly, with regard to
maybe briefly, so that we have.
And lastly, thank you. Lastly, in terms of monitoring, this is through the quarterly meetings and updates that we get from countries, and where we participate in trying to resolve and address the bottlenecks. Thank you, Patrick.
Great, thank you, team. And I know that the team can follow up with you on any other questions that they may have. And thank you very much for responding to the questions. Dr. Ndindi, well done to Kenya for having a very strong plan. briefly, could you tell us what is the most urgent health system barrier to quality services, and how will we address this in Kenya and I believe in other countries too? We've been talking of the first 395, but I believe the fourth 95 has to do with quality of services that we really offer to the children that we serve. So what is the most urgent health system barrier in against quality health services?
Thank you for the question. To answer it, the most urgent health system barrier to quality services is access. And access can be in several ways. One could be the financial access, where the population or people are not able to, where people are not able to get to the facilities because they do not have the money to get there. The other one is access just where the facilities are. And what has been done in Kenya is currently we are working with the universal health coverage that ensures that all populations are able to access quality health services, but also several health facilities are being put up really nearer where people are. Like in one of the counties that is in Nairobi, we had an initiative by the leadership to just, actually the president, the former president, to build facilities in the informal settlement so that the people that are in those populations or living in those areas can be able to access health care. I think that's the response I can give for now for that question. Thank you.
Yeah, thank you. Maybe as a follow-up, and I know if the reason why we must have a clinic community linkage is to be able to reach those who are still at the community who have difficulties accessing services. But let me add, there's a question about, you mentioned all populations. What specifically are we doing to the key populations? Are the children of female sex workers, for example? There's someone who has asked a question that is due to Lamini from Sweat in South Africa. What are we doing for the children of the key populations? Just a question.
Okay, for the key populations, what we've done, one of the areas where we have targeted to have healthcare workers trained at the diocese, the drop-in centers for the key populations. And also we are working on a tool or a structure of linkage, which is already there, but really strengthening it so that the mothers and the children who come to the diocese and need further services, PMTCT services, or Kale HIV care and treatment services are linked to nearby facilities, and follow-up is done appropriately. Thank you.
All right, great. I know we have a lot of questions, but let me bring in Dr. Mahomva again. As leaders on the Africa Reach Council, what are you doing to address some of the barriers and inequalities that we still have in reaching the populations? And what can you say is the commitment of the Leadership Council? What is the Leadership Council committing? That's Dr.
Thank you
Mahomva.
very much. Yes, thank you very much for that question. We're really excited, as some might know, the Africa Reach Leadership Council is a new organization, but our focus is really making sure that we are having those collaborations with those that care very much about ending HIV and AIDS in children, hence our participation here. So that's really key. And of course, working and collaborating with those that mobilize resources, whether you're looking at advocacy for pediatric issues to be high on the agenda for the global funds and other funders, for example, and of course, the implementing partners, working with them to really sharpen those strategies that we're seeing, a lot of them actually being presented here. I want to really commend the Kenya experience and the way they have put together very nice a plan that clearly articulates what needs to happen and very strategic. And those are the issues that we are pushing forward as a Africa Reach Council, Leadership Council, to really make sure we have strategies that are homegrown and make sure that as Africa, we're leading the initiatives. We are not depending on others. As you know, when we started HIV/AIDS, there was a lot of cry, let's have funding from Global Fund, let's have funding from so-and-so. But we're saying, what is it that we need to do as a Leadership Council, as Africa in general? Those homegrown solutions is what we are really focusing on and pushing so very hard. Thank you.
Wow, great. Thank you, the presenters and all the contributors. Thank you for the team that has attended this session. I know that we have more questions, but because of time, we'll have to stop. There are questions in the group there to our presenters. If you can type your responses, or we'll look for a way in which we can share these questions with you so that we can be able to respond to them. So as I end, this is just to remind us that we are the advocates for these children. They cannot do it by themselves. So you are in that position that you are in currently to fill a gap. But yes, we appreciate that the health workforce, the human resource for health, the carer also need to be cared for. There was a statement from Luen's presentation that we have health workers who don't feel appreciated. And I know that there are program managers who are attending this session. What can we do to make sure that even the health workers are motivated, take care of the mental health aspect, so that the quality of services that we offer to our clients, to the children, is top-notch out there? How can we borrow from each other? East Africa, South Africa, Central Africa, West Africa. That PATA effect has to be felt, and it can only be felt if each of us are going to look at the plans that we have and we are going to implement them. We have to end this session. Thank you very much, and we look forward to meeting in the other satellite sessions. Over, back to you. Let's appreciate the team even as we end the session.
Thank you.
Thanks, Dr. Patrick. Thanks, everybody. Thanks so much.
I think the reality is that we're still very far from ending new infections in children. If you look at the data, it's clear that our progress has flatlined. We still have over 160,000 new infections in children every year. There is a huge gap between children and their mothers with respect to access to treatment.
Many communities are faced with real structural barriers: stigma, discrimination, punitive laws, violence, social, cultural, gender inequalities.
Frontline healthcare workers are the critical piece of the puzzle that's been missing in solving the crisis of pediatric HIV infections.
They're the ones who drive this movement to end AIDS.
We believe that we can have all the health systems we need, we can have all the drugs we need, but without trained, capacitated health providers, we will not be able to achieve our goal.
And PATA stands out for that reason alone, in just focusing on what's needed to actually provide care.
The health provider situation in many countries in Africa is a concern. And PATA presents an opportunity for these health providers to provide stories of the real situations they're facing on the ground.
We want to look into a different perspective for them to voice their feelings, their stress, their challenges.
They're working under extremely difficult circumstances. It's demotivating to work in a broken health system. It's frustrating to watch patients get sick. It's frustrating to watch patients die, especially when they're children. Healthcare workers have the right to be compensated for their time. They have the right to work in a safe and supportive environment. To me, it's critically important that PATA's mission of supporting and sustaining frontline healthcare workers is recognized.
We cannot make policies without understanding what health providers' needs are.
To be able to have the voices of the frontline health providers influencing decisions at the top levels of national and global policy, and to link on those policies to the front lines of health is one thing that I haven't seen as effectively implemented than by PATA.
So the Global Alliance is a recently launched collaboration. The Alliance is coming together with countries to try to tackle 4 areas where we want to see progress happening.
Through this Global Alliance of Ending AIDS, we need different stakeholders, and frontline health providers are most important. If we are leaving them behind, I don't think we are going to reach there in our targets.
What we really need to get right is the integration of HIV services into primary healthcare settings.
A huge part of that health system are the frontline healthcare workers. If we're not supporting them, we don't have a healthcare system.
And it's therefore critical that we acknowledge, celebrate, support, and value the work of frontline health providers and make sure that we are providing sufficient investments directly to the front line.